Hello, my name is Christopher Periera, and I'm going to talk about cerebral vision impairment today. The title of my presentation is Unremarkable. So what is cerebral vision impairment? It's sometimes referred to as cortical vision impairment or cortical blindness, but these terms have fallen out of favor as cortical is no longer the preferred term, as extracortical damage to the visual pathway can still result in CVI. Blindness is no longer the preferred term, as total blindness cannot result from CVI due to the plasticity of the central nervous system and the extragenicular striate visual pathways. CVI results from damage to the retrogeniculate visual pathway in the absence of ocular pathology. Visual outcome is related to the timing, degree, duration, and mechanism of brain damage. So how prevalent is cerebral vision impairment? The incidence is 161 per 100,000 births, and this has increased since the 1980s, where the incidence was 36 per 100,000. CVI has recently become the most common cause of severe vision impairment or blindness in children from developed countries, accounting for about 30% of all cases. This is due to two reasons, one of them being the improved management of treatable causes of childhood blindness such as retinopathy of prematurity, glaucoma, cataracts, and even amblyopia. Secondly, this can be due to the improved intensive care of infants and children with cerebral pathology who decades ago would likely not survive. So what are some common causes of cerebral vision impairment? Hypoxic ischemic brain injury accounts for about a third of all cases and is the most common cause of CVI. In full-term infants, this can result from infarction of the frontal and parietal occipital areas, and in preterm infants, this can result from periventricular leukomalacia, or PVL for short. Meningitis can cause damage to the occipital cortex, as it's particularly susceptible to damage by Haemophilus influenza. Hydrocephalus can also cause CVI due to the chronic distension of the posterior cortex. Interestingly enough, shunt malfunction as well as rapid correction with shunts can bring about CVI as well. Trauma accounts for about 4% of all cases of CVI, and about 50% of those cases are due to child abuse. Shaken baby syndrome is a common cause of traumatic cerebral vision impairment. Other causes include epilepsy, congenital brain malformations, metabolic disorders, hypoglycemia, hemodialysis, CVA, and tumors. Though CVI in a vacuum does not result in damage to the ocular structures, ocular and systemic findings are not uncommon. This is because etiologies for CVI are not specific to the post-chiasmal visual pathway. Optic atrophy is found in about 40% of patients with CVI, and this can be due to hypoxia or papilledema secondary to hydrocephalus. Hyperopia is commonly found, as well as strabismus, usually infantile exotropia in the case of full-term infants, and esotropia found in cases of PVL in preterm infants. Additionally, nystagmus can be found in cases resulting from subcortical damage or if there's damage to the anterior structures such as the retina or optic nerve. Visual field defects are not uncommon, with the most common being bilateral inferior defects due to damage to the optic radiations or homonymous hemianopia. Other neurological disorders are associated, such as cerebral palsy, intellectual disability, hemiparesis, hearing difficulty, abnormal mental development, behavioral problems, spinal bifida, progressive degenerative disorders, and hypotonia. Patients and children with cerebral vision impairment will exhibit certain neurobehavioral signs such as light gazing, or the tendency to look at bright lights and moving your hands against the light in front of their eyes. This is thought to stimulate the photoreceptors as well as the visual system. Mechanical stimulation of the photoreceptors is also not uncommon, such as the case of eye pressing. It's also common for there to be a latency or delayed response to visual stimuli, and there's almost always a good response to color, even in the context of poor measurable functional vision. This is thought to be due to the bilateral cerebral representation of color. Visual function is often variable throughout the day, and it's often better in familiar environments. Patients often shut down in visually cluttered or unfamiliar environments or when fatigued, as is the case when they often go to their eye exams. The phenomenon of blind sight can partially explain how patients can navigate busy environments, and it's the ability to respond to visual stimuli without conscious perception. The diagnosis of cerebral vision impairment is usually made using the help of clinical examination and neuroimaging. CT and MRI findings often show altered anatomy of the posterior visual pathway. MRI is most sensitive for establishing damage to the periventricular white matter, such as in the case of PVL, as you can see in the top right image. PVL severity has prognostic implications on future vision. MRI is helpful in revealing cortical thinning, decreased underlying white matter, ex-vacuole dilation of the ventricles, as in the case of hydrocephalus in the bottom left image. Eulogria, which is misshapen narrow gyri, and wedge-shaped infarctions are often found in hypoxia, which you can see in the top left image. VEP is occasionally used, however the information and applicability is controversial. Hoyt categorizes individuals with cerebral vision impairment into one of 6 levels, with level 1 being the child could only perceive light at the time of the examination. In level 2, the patient could occasionally fixate on large objects, faces, or movement in the environment. Level 3 is if the visual function is highly variable, but with at least some moments of good visual fixation, as indicated by the ability to see small objects, such as coins or stickers, or if the patient can reliably visually fixate a face. Level 4, the patient could reliably fixate on small targets and/or measurable acuity in the 636 to 660 range. In level 5, there's good reliable fixation and/or visual acuity measured under binocular viewing conditions of 618 to 636. And level 6, there's a completely normal sensory visual examination. You can simplify these levels as level 1 being light perception, level 2 is the occasional fixation of large targets, faces, or movement, level 3 is the occasional fixation of small objects or reliable large target fixation, level 4 you can think of as reliable small object fixation and 2120 to 2200 acuity, level 5 is reliable small object fixation with 2060 to 2120 acuity, and level 6 is functionally unremarkable. So what is the visual prognosis for cerebral vision impairment? Fortunately, most if not all patients with CVI will demonstrate some improvement in vision. In cat and non-human primate models where the visual cortex is completely ablated, retinal projections are still able to reach the extrastriate cortex by way of the thalamus. Aside from reduction in visual acuity, patients can exhibit higher visual deficits, such as difficulty perceiving motion or spatial orientation. It's important to understand that not all of vision is just V1. A retrospective study found visual improvement of 78% of patients with cortical damage and 42% of patients with subcortical damage. However, 90% of patients with CVI remain visually impaired in some capacity. Visual outcome is related to the timing, degree, duration, and mechanism of brain damage. As such, no 2 cases are the same, and there is significant case-by-case variability. The aim of vision rehabilitation in the context of cerebral vision impairment is to increase the complexity of the patient's visual world in a controlled manner. You can see this referenced on the images on the right-hand side. First, you see the image of a bird, which is outlined with no detail. Then you see the image of a face, which is the outline of the head with some simple facial details added. And lastly, you see the outline of a butterfly with complex details added. These images are often introduced to children on a light board or on a tent, and this is to actively engage the child as well as block out potential visual distractors. A study involving 21 patients selected individuals with cerebral vision impairment with a visual level of 3 or lower. They were placed in an intensive 13-month-long vision rehabilitation program. 76% of the subjects improved from visual level 3 or below to level 5 or higher, compared with 19% of controls in an older study. 14% of patients improved 2 levels, 29% of patients improved 3 levels, 33% of patients improved 4 levels, and about half of patients were reading at the conclusion of the program. So what is our role as optometrists or eye care providers in the care of patients with cerebral vision impairment? First and foremost is taking a detailed functional case history. As we learn, the visual function of patients with CVI is often variable and often worsens in unfamiliar or visually complex environments such as the eye doctor's office. It's important to assess functional vision and not just acuity. You may not always be able to get a Teller or Snellen acuity on these patients, and you may have to rely on your transilluminator, yellow pom-poms, or mirrors for eye tracking. It's important also to rely on parents and their teachers for their functional history. Cycloplegic refraction and dilated fundus exam should be performed, and this is to diagnose and treat any clinically significant ocular comorbidities such as refractive error that's amblyogenic, cataracts, or glaucoma. It's important to connect the parent with resources such as early intervention, which is an Illinois program for children ages 0 to 3 with disabilities or delays. The state offers services such as PT, OT, and vision. It's important to educate the parents on the condition, visual potential, and strategies they can employ at home, such as using high contrast colored moving targets, reducing visual clutter, allowing for extra response time, and incorporating auditory and tactile cues. Because cerebral vision impairment does not exist in a vacuum, these patients are often under the care of a neurologist by the time they get to their eye doctor. However, some differentials such as autism spectrum disorder, ocular motor apraxia, and delay in visual maturation should not be ignored. I want to quickly run through some cases here. So case 1 is a 23-month-old female with history of premature birth at 30 weeks and intracranial hemorrhage. The patient stopped receiving early intervention services due to challenges with her home situation. Mother reports occasional eye contact and that her daughter enjoys looking at lights. The patient cries when the lights are turned off and gets easily overwhelmed in busy environments with visual and auditory stimuli, such as arcades. We were unable to measure an acuity on teller, however, she demonstrated a positive OKN response, equal resistance to occlusion, and was able to fixate and follow a yellow pom-pom. Pupils were unremarkable. We were unable to test confrontation fields due to the patient's visual inattention. The patient was aligned on Hirschberg and demonstrated a moderate nystagmus and full range of motion. Cycloplegic retinoscopy was plus 550, minus 1, axis 180 in the right eye, and plus 450, minus 1, axis 180 in the left eye. Slit lamp and dilated fundus exam were unremarkable. We recommended the mother that they restart early intervention services, including vision. We prescribed a spectacle RX for full-time wear in polycarbonate because the prescription is amblyogenic, and we educated the mother that the spectacles may not improve her daughter's functional vision. Our second case is a 25-month-old male delivered via C-section at 34 weeks due to hydrocephaly and is status post-shunt. The patient is currently enrolled in early intervention services and is receiving occupational, physical, speech, and developmental therapy. The patient started vision services 2 weeks prior. Mother reports that he's doing well at daycare and can reach and accurately grab objects. He enjoys looking at lights and hasn't demonstrated a preference to color yet. We were unable to measure a teller acuity on the patient, but he was able to demonstrate a positive OKN response, equal resistance to occlusion, and was able to fixate and follow a transilluminator and yellow pom-pom. Pupils and confrontation fields were unremarkable and was aligned on Hirschberg. The patient demonstrated a limited superior gaze, and this is likely due to visual inattention. Cycloplegic retinoscopy revealed mild astigmatism, and slit lamp and dilation were unremarkable. There was optic nerve head pallor noted on a single ophthalmology note in 2018, but not on previous or subsequent ophthalmology notes. We recommended that the patient continue with early intervention services, including vision, and that the patient continue without spectacle correction at this time. Our third case is a 5-year-old female with history of traumatic optic atrophy and global developmental delay secondary to shaken baby syndrome. The mother reports that her daughter does not wear her glasses because they're too small, as they're from an exam 3 years prior. The patient is receiving physical, occupational, speech, and vision therapy in school. Mother reports that her daughter can track and accurately grasp objects. Visual acuity was measured at 0.27 cycles per centimeter on teller. The patient was able to demonstrate a positive OKN response with equal resistance to occlusion. Pupils were unremarkable and confrontation fields were grossly full. Cover test revealed a 30 prism diopter constant alternating exotropia with mild surging nystagmus. Cycloplegic retinoscopy revealed plus 250, minus 150, axis 180 in both eyes. Slit lamp and dilation were, anterior slit lamp was unremarkable, and DFE revealed mild optic nerve head pallor, not in proportion with the level of acuity. We recommended that the patient continue with vision services at school, and we updated her spectacle prescription. We educated the mother that the spectacle prescription will likely not improve her daughter's function. Our last case is a 12-year-old male with history of seizure disorder. The patient achieved normal developmental milestones until the age of 4, where he began developing uncontrolled seizures. He's currently controlled with Keppra, Onfi, and baclofen, and his last seizure is over a year ago. The patient has generalized muscle weakness, is wheelchair-bound, and nonverbal. The purpose of today's exam is to evaluate vision as it relates to a potential communication board. The patient is currently receiving occupational, speech, and physical therapy. We were unable to measure a teller acuity on the patient, and the patient was not able to demonstrate a positive OKN response. The patient was also unable to fixate and follow. The patient, however, did demonstrate equal resistance to occlusion and did demonstrate 20/50 acuity on Cardiff. Pupils were unremarkable and fields were full. Cover test revealed a 20% diopter constant left exotropia. Dry retinoscopy revealed +50 in the right eye and +2 in the left eye, and slit lamp and dilation were deferred as the patient was already under care of an outside ophthalmologist. We recommended that the patient begin vision services in school, as well as continue forward with the visual communication board. We recommend that the patient continue without spectacle correction at this time, as the patient was already under the care of an outside ophthalmologist who recommended against spectacle correction. In conclusion, the challenges these patients face are not limited to vision, and these patients require a diverse, team-based approach, not just for diagnosis, but also for optimal continued management. As advances in healthcare emerge, it's likely that the prevalence of CVI will increase. It's important as eye care professionals to understand this condition, as it can be a source of confusion and frustration for patients, family members, and other health professionals. Early diagnosis is key to favorable rehabilitative outcomes. Special thanks to Dr. Crumblis, my co-residents, and everyone watching this at home today. These are my references. Thanks again.